Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Hello, everybody. My name is Cesar Alves, and today I'll be talking about neuroimaging mitochondrial disorders. These are my disclosures for this presentation. And the purpose of this lecture is make you able to recognize imaging features of mitochondrial disorders, recognize the most common syndromes, not only the classic features, but the early imaging findings for the most common syndromes, and also when the imaging has a good match with the genomes and pathogenic variants. Before starting talking about imaging findings, let's talk quickly about concept and terminology. What is a primary mitochondrial disorder? Primary mitochondrial disorder is any kind of disease that may affect the mitochondrial function and be related to the dysfunction or the pathogenic variants in the mitochondrial genome or nuclear genome. So remember, primary mitochondrial disorders are not necessarily related to the mitochondrial genome. Actually, the most common genes that cause mitochondrial dysfunction are pathogenic variants in the nuclear genome. In other words, any type of pathogenic variant affecting nuclear genome or mitochondrial genome that cause a primary dysfunction of the oxidative phosphorylation can be called a primary mitochondrial disease. Interesting, when you look for what we know nowadays, we can see, as I said, majority of the genes that are recognized for primary mitochondrial disease are nuclear genes that affect the mitochondrial function. We also know some mitochondrial genes causing primary mitochondrial disorder, but the majority of pathogenic variants, pathways, interactions, we still don't know. With that in mind, I'm bringing to you the scenarios that you need to recognize from the image point of view, and you should consider primary mitochondrial disorder. So let's start with this patient. This is a 13-month-old male patient with hypotonia and parent milestones. Look for these lesions here. As you can see, these lesions are very symmetrical. These are diffusion, ADC map, and T2. The symmetrical lesions in the putamen, they have components of restricted diffusion and components without restricted diffusion. So this is the first rule. Don't think that just because of mitochondrial disorder, you see lesions, homogeneous lesions with restricted diffusion. Actually, that's not true. The most common form of lesions, the lesion appearance in the diffusion is the presence of components of restricted diffusion and components without restricted diffusion. So this is the most common form. Involvement of the brainstem tends to be very characteristic because lesions tend to affect particularly the substantia nigra and periapital gray matter, sometimes expanding, going laterally to the medial lemniscus. So this is a classic imaging finding for Alves syndrome. In this case, was confirmed pathogenic variant in the ND3. Look again, another case with similar features, although in this case you see involvement also the caudate and the globus pallidus, the involvement of the thalami extending along of the third ventricle. You can see again components of restricted diffusion, components without restricted diffusion, which is very characteristic. Involvement of the substantia nigra, and in this particular case, also involvement of the cerebellum. And this was a confirmed ATP6 pathogenic variant, which is quite common in the context of Alves syndrome, particularly when you see involvement of the cerebellum. So remember, for the diagnosis of Alves syndrome, you need to find classic imaging features along with clinical symptoms underlying considering Alves syndrome and confirmation based on genetic results. Just show again how you can have the diagnosis of Alves syndrome. So you need lesions in the basal ganglia and or lesions in the brainstem. The basal ganglia tend to be much more common involvement of the striatum with components of restricted diffusion, but sometimes only involvement of the glow spiders may happen. And when you look for lesions in the brainstem, you need to recognize specific locations. The most common ones: the substantia nigra, oculomotor nuclei, pectoral gray matter, colliculi, the superior colliculi, the involvement of the inferior vestibular nuclei in the inferior cerebral peduncles, and the leaves, the inferior olivary nuclei. So these are the classic and common findings in the brainstem that are related to Lake syndrome. As I said, since the components of restricted diffusion are not homogeneous in the basal ganglia, sometimes you may see this target sign. This target sign may help you to think about Lee syndrome. Involvement of the brainstem, particularly substantia nigra, and when you see lesions in the pectoral gray matter extending laterally to the medial meniscus, think about Lee syndrome. It's quite characteristic. Sometimes aggressive lesions may evolve necrosis, so you may see suppression or flare, like vanishing appearance of the parenchyma. It can be in the brainstem or in the basal ganglia, also very characteristic. Let's bring some important questions in this scenario. First common question that clinician may bring to you is, can it be hypoxic injury or this is a Lee syndrome? This is an interesting result that we are working on newborn onset for mitochondrial disorders. And interesting, different than expected, we don't see many lesions in the basal ganglia and brainstem for patients that have an onset, very early onset, less than 1 month old age. Normally, in the newborn onset, these lesions tend to be much more in the white matter with components of restricted diffusion. Hemorrhage is not a common finding for mitochondrial disorders. Let's clarify that. But in the newborn onset, this particular subset of patients, you may see lesions with hemorrhage, particularly involving the parenchyma and the deep white matter, periventricular white matter. You also may see abnormalities of the corpus callosum, so malformation of the corpus callosum, septation inside of the ventricles. And remember that this feature here is very characteristic for PDH. So PDH in the prenatal onset may bring classic imaging findings, including malformation of the corpus callosum. The corpus callosum tends to be very small, uh, as you see here. Enlargement of the ventricles, asymmetric enlargement of the lateral ventricles, uh, volume loss of the white matter, and septation, as you see here. I'm bringing a differential that perhaps can be useful if you don't see malformations of the corpus callosum, but you see conatal cysts, septations inside of the ventricle, but no malformation of the corpus callosum. Remember about MG82. So it's like PGH, but without classic features, the malformation of the corpus callosum. So maybe a mimicker for PGH, and it's nice to remember about this other pathogenic variant. Another common question is, what else can I say in my report? So if I'm discussing with the neurologist and I'm telling, oh, I think this is Lee syndrome, can I say something else about genes, genomes, or pathogenic variants? So the answer is yes. If you see a patient with Lee syndrome, classic features in the basal ganglia, brainstem, your clinician is considering Lee for your patient, look for involvement of the white matter. So if you see this pattern that seems like a leukodystrophy pattern, think about the nuclear genes, the nuclear genome that normally is much more associated with leukodystrophy pattern in the context of Lee syndrome. If you see cortical lesions and Lee syndrome, think about mitochondrial genome. So cortical lesions and involvement of the brainstem and basal ganglia, think about the mitochondrial genome. Involvement of the white matter and basal ganglia, think more about the nuclear genome. We can at least divide these things in two main groups. And remember that these lesions involving the cortex may come just in follow-up studies. So if you see a patient with Lee syndrome and involvement of the mitochondrial genome, be aware that cortical lesions may come in the follow-up studies. This rule also works for nuclear genome and involvement of the white matter. Sometimes subtle changes in the white matter at the onset may become very evident in the follow-up studies. Another question that we always think is about Lee syndrome without basal ganglia lesions. So it's possible, since we have discussed it before, you may have Lee syndrome with basal ganglia and or brainstem. So you may have patients with only brainstem involvement. I'm bringing to you two different patients here, patient number 1 and patient number 2, both of them mainly with lesions in the brainstem. This also with some involvement of the thalami, but no lesions in the basal ganglia here, just a small spot on the right putamen. Both patients confirmed as Lee syndrome. We always think about Lee syndrome without involvement of the basal ganglia in the context of SIRF1. So SIRF1 is a common gene associated with Lee syndrome and with a phenotype of sparing the basal ganglia. But we have noted that majority of the patients with SIRF1 sparing the basal ganglia, they have also involvement of the olives. So the olive can be very helpful for you to think about SIRF1 when you don't see lesions of the basal ganglia. And if you don't see involvement of the olives, think about ND5. Just to show another example, another case that came recently to in our hospital, and a patient is concerned for Lee syndrome. We don't see lesions in the basal ganglia, but we are still considering the clinical scenario for Lee, and there were no lesions in the leaves, and this was confirmed in 85. Okay, so let's move for the scenario number 2. This is a male patient, 11 years old. Patient was small, with weakness, cesarean hearing loss, and acute stroke-like episodes. Look for the imaging findings here. We are seeing involvement of the cortex going beyond the limit of the arterial territory. The posterior, occipital, and temporal lobe both are affected. I'm bringing the diffusion, but the dates map was not showing restrict diffusion throughout this area that was affected, but there are components of restrict diffusion. You can see increased perfusion in the area that was affecting the ASL. Also engorgement of the posterior cerebral artery in the MRA, and also engorgement of the veins, and also increased deoxyhemoglobin, uh, as you can see here in the middle cerebral vein. When you go to the spectroscopy, you see increased lactate peak in 1.3 and reduced NAA. So all these features are very characteristic for Milas. Yeah, this is the classic form of Milas that you need to recognize. Remember that Milas in 80% of the time will be related to the same pathogenic variant affecting the MTTL1. 3243 is a very common pathogenic variant related to Milas. And Milas patients, they may have seizure, recurrent headache, vision and hearing loss, fatigue, loss of the motor skills, short stature, and lactocidosis. When you look for the imaging features and you see the imaging features that we have just discussed, these are enough for the criteria to call these patients as Milas. A neurologic question. And if the neurologist sends me Milas patient with new metabolic stroke episodes and I don't see the lesions, so the patient's coming again, seizing, concern for new stroke episode, and we go to the brain, the standard T2, flare, diffusion, and you don't see the cortical lesions. Remember about the importance of the advanced techniques. So this is the follow-up study of that prior case that I just present to you. And in the follow-up study, you don't see anymore the cortical lesion involving the right hemisphere. So the right occipital lobe, perhaps there are some volume loss, but no acute cortical lesions here. No lesions on the left. But when you go to the MRA, you see engorgement now in the left posterior cerebral artery, and the ASL increased hyperperfusion, increased perfusion now in the left occipital lobe. Just to remember that the engorgement of the posterior cerebral artery in the baseline MRI was on the right and now is on the left. So remember the importance of advanced techniques, and sometimes the MRA may be the only ones able to help you when you recognize new stroke-like episodes and events with involvement of the parenchyma. Okay, another question to you. What should I know from the typical forms and outcomes? So not always as simple as we have learned for the cortical lesions in the context of Milas. Sometimes Milas may present like that. So this is a 2-year-old patient with development delay, stroke-like episodes. The clinician was asking a potential Milas, could be a Milas for this patient, although this patient was normal height and weight, no sensorineural hearing loss, no vision loss, and no headache. When we look for the MRI, we see multiple cortical lesions. So these lesions are not anymore just large lesions, the occipital and temporal lobes, but scattered cortical lesions throughout the brain with components of restricted diffusion. And when you go to the spectroscopy, you can see a very high lactate peak in 1.3 ppm in the intermediate echo. So this patient is also a Miller's patient, although with a typical form. Remember, I'm just showing another patient to you, 4 years old male patient, again with development delay and stroke-like episodes. Again, normal height and weight, no sensory hearing loss, no vision loss, and no headache. And we are seeing now cortical lesions more in the frontal lobe, also in the perilymph region on the left, and also involvement of the basal ganglia. So there is some overlap phenotype with Lee syndrome. So remember that Lee syndrome and Miller's, they may have some overlap features, and this is some kind of atypical form of Miller's. You may also see atypical cortical lesions that are present in the context of Miller's, and sometimes only the cerebral involvement. All these features are recognized nowadays in the context of atypical Miller's. And this atypical Miller's has a poor prognosis when compared to the classical ones. So this is just a flow chart that may help you to understand how to divide Miller's between classic Miller's, the one that goes to the cortex, more just like one or two very large lesions affecting the posterior and lateral aspects of the brain, occipital and temporal lobes, sometimes the insula, which differentiate from atypical lesions that normally are associated with Lee syndrome. And when associated with Lee syndrome, you see these scattered cortical lesions throughout the brain without the typical features that we have learned before. Okay, so let's move to the scenario number 3. Let's talk about cancer now. So this is just a very good example, clinical example of the ophthalmologic changes that we see in patients with cancer. So you can see ptosis bilaterally more on the left, and impairment of the ocular motricity. So these are classic features for cancer in a patient with when you go to the ophthalmoscopy, you see retinal changes with pigmentary retinopathy. And but when you go to the brain, when you think about cancer, the first place that we go is for the white matter. And as you can see, the white matter changes are not characteristic in this case. On the other hand, you see mostly of the lesions involving the basal ganglia, particularly the globus pallidus, with questionable components of retinal diffusion, and brainstem standing out the substantia nigra. The features that we see in the early stage of disease are not the classic features that we learn in the red for cancer. And the class features that we know are the involvement of the white matter, particularly the superficial white matter with these dark stripes. These dark stripes are very characteristic for cancer, not commonly seen in other neurometabolic disorders affecting only the superficial white matter, sparing the deep white matter. Involvement of the basal ganglia, particularly the globus pallidus, sometimes with iron and calcification. You may see increased signal on diffusion and involvement of the brainstem, particularly, as I said, the substantia nigra. Remember that these patients, they normally they have cochlear implant and pacemaker at some point of the disease progression. And just to recap, the teaching imaging findings that you need to remember for cancer, remember always about the involvement of the brainstem, particularly the substantia nigra. The involvement of substantia nigra is normally present since the beginning of the disease, along with the superior cerebral peduncles and pectoral gray matter. So these structures are affected since the beginning when you are considering cancer. The involvement of the basal ganglia is particularly noted with lesions in the globus pallidus. So the globus pallidus is present in 90% of patients with cancer. Remember that you may see increased diffusivity, increased signal on diffusion, although true restricted diffusion is not commonly seen. Involvement of the corpus callosum normally sparing the boundaries is very characteristic as well. And the white matter, as I said, not a common finding in the early stage of disease, but very characteristic for cancer, normally with these dark stripes that may help you in the diagnosis. Also important to know that the changes in the brainstem, they tend to be very uh, strongly related to clinical symptoms, for instance, involving substantia nigra with Parkinsonism, oculomotor nuclei and medial longitudinal fasciculus with impairment of ocular motricity, involvement of superior cerebral peduncles in patients with ataxia and apraxia, and facial nuclei and middle cerebral peduncles in patients with dysphagia, deafness, and ataxia. There are some potential grades that we may think, since we understand more or less how the disease progresses over time. We see that majority of the patients with diffuse involvement of white matter, they tend to have a poor outcome at the late stage of disease when compared to those that you see only involvement of the basal ganglia and brainstem without involvement of the white matter. With that, we are proposing a potential natural history from the image point of view with upward distribution of the lesions starting the brainstem, going to the basal ganglia, and later on involving the white matter, which tends to start the parallel region, spreading to the other uh, parts of the superficial white matter, including also uh, the infraterritorial compartment, cerebellar white matter. So these are expected longitudinal changes that we see in patients with cancer more than 80% of the time. And just to bring again the importance of dark stripes that may help you to recognize cancer when compared to other neurometabolic disorders, including, for instance, L2-hydroxyglutaric aciduria, that we also normally see involvement of the superficial white matter, sparing the deep white matter, but without the dark stripes that are much more characteristic for cancer. Okay, so let's talk quickly about white matter involvement in primary mitochondrial disorders. We know that the majority of mitochondrial disorders, they tend to affect the microglia and the astrocytes. I'm just bringing here because this is interesting to know. These are animal models, mice, with involvement of the brainstem. These are actually the vestibular nuclei. You see these lesions in the vestibular nuclei bilaterally. And when you go to the histology, these red components here are related to hypertrophy of the astrocytes, and in blue here, the proliferation of the microglia. So even in the gray matter, you see increased components of the white matter cells. So remember that not all the brainstem and basal ganglia, even the nuclei, are composed only by gray matter. And these are the imaging finds that I want you to keep in mind for the most classic form appearance of white matter involved in primary mitochondrial disease. So you see these areas of restricted diffusion, like lamellar areas of restricted diffusion, extending with components of cavitation and cystic degeneration. So these are the classic features that you need to recognize and think about primary mitochondrial disease. Okay, so let's move on for the scenario number 4. This is a female patient, 13 years old, with confusion, left optic neuritis, and a family history of vision loss. What we are seeing here, we are seeing lesions in the thalami, asymmetric lesions in the thalami, right more than left. You can see the optic neuritis with signal chains, enlargement of the left optic nerve, involvement of the spinal cord. You will see the age sign, so the age sign related to gray matter hyperintensity that stands out when you look for the cross-sectional images of the spine, again, in the dorsal, the thoracic level. All these image features very characteristic for MOGAD. But in this particular patient, we were looking for the family history. So remember that I said there is a family history of vision loss. So we move for evaluation of potential pathogenic variants related to Leber. And this patient was also confirmed for Leber hereditary optic neuropathy. So remember that sometimes you may see association between inflammatory disorders and mitochondrial disorders. So this was a case that was confirmed as Lihon plus Mogad. Just showing a very beautiful example for a colleague, uh, Dr. Raul Lashman. He gave this beautiful case showing involvement of the optic nerves, left more than right, going through the optic chiasm and optic tracts bilaterally. And the follow-up studies more with residual chains throughout the optic pathway. Remember that normally Lihon tends to be very specific for the optic pathways, including optic nerves, tracts, as you see in this case here. As I said, inflammatory disorders, particularly multiple sclerosis, may be associated with Lihon. So remember that potential association between both entities, we call it this Harding syndrome when you see Lihon in association with multiple sclerosis. It's something that you need to keep in mind. This association may happen, and not because you see features relate to neuroinflammation, you will not have mitochondrial disorders. Actually, this correlation may happen and is not so uncommon, particularly in the context of Lihon. I also want to point out the importance of the involvement of the spinal cord in patients with mitochondrial disorders. So involvement of the spinal cord tends to be neglected, but it's a common finding actually when you look for these patients. We may see lesions like this one that similar to NMO, they are longitudinal extensive, including the involvement of the area postrema. Sometimes you may also see the bright spots that are very characteristic for NMO, and sometimes you don't see the markers for NMO, so anti-acroporin 4 negative, as was in this case, and that at the end was confirmed as a mitochondrial disease. And sometimes you may see lesions only close to the conus in the more distal aspect of the spine, giving some involvement more in the gray matter, sometimes mimicking ischemic chains. So these are also common findings for primary mitochondrial disorders involving the spine. With that, I finished this lecture. I want to say thank you to my friends that helped me in the study of mitochondrial disorders, and I hope this lecture may help you in recognize, as I said, the most common syndromes in the early stage, and also the classic features, and also may help you to recognize those syndromes and imaging find that may have very good correlation with pathogenic variants and genomes. Thanks so much.